Whcr 90.3 FM. Peace.
WHCR 90.3 FM, New York.
Good evening, ladies and gentlemen of the listening audience. This is Sean Shiver, the Director of Food and Nutritional Services at Harlem Hospital Center.
And this is Ayana Cole, a fourth-year student at the Sophie Davis School of Biomedical Education.
And you're listening to Health in Harlem. And our topic tonight is pain, chronic pain. I'm going to say it again, is that you should not be in pain right now unless you are sitting in the hospital. Not even that.
True
but need to get yourself checked. So today, our conversation is going to be about pain. And again, Dr. DeCastro, thank you for coming on to the show.
Yes,
Absolutely.
Thank you
for inviting
So
us.
before we actually get into, we have an announcement, Ayana?
Yes, we do. Harlem Hospital Walks Committee 6th Annual Happy Feet Dance is going to be on October 16th, 2015. We have music by DJ J Live. Ooh, okay. From 6
You
p.m.
better say ooh.
It starts at 6 p.m. and it ends at 10 p.m. on the 5th floor of the Alhambra Ballroom on 2116 Adam Clayton Powell Boulevard at 126th Street. So admission, you can check the website for admission, actually. You can visit...
It's been at the very bottom, I think.
Actually, yeah, Valerie Wright is one of the contacts. So valerie.wright at nychhc.org, or you can call 212-939-4072. Please come. There's going to be music, games, raffles, a dance contest, prizes, special guest appearance, and we're getting honored. Ooh.
But I'm not going to be there.
Oh, that's okay. I'll hold it down.
That's
me and
okay.
Maurice, me and Mo.
Hey. All right, so let's continue our conversation. Right before we went on break, actually, I want to say thank you, Dr. DeCastro, because breaking pain down in such a different way,
Right.
that kind of makes sense. Mm-hmm. But Ayana, you was talking about
misconceptions of
thank
pain.
you.
There's a lot of stigma when it comes to having pain. People always assume, like, oh, you're in pain and no big deal. You'll get over it. But people don't really understand that it's not just chronic pain. It's not just in my head, or it's not just in the person's head. So what do you say to those people?
Well, talking about misconception, I think of right now a condition called phantom pain.
Mm-hmm.
And most of the people actually address that, it's in your head. And I'll give an example. Someone that has an amputation of any limb will complain of having pain in the phantom extremity.
I heard about that.
I heard about that too. And I also heard about that treatment where you put the mirror on the other so that you can see the opposite limb.
The opposite limb, right. So, and it actually is not in their head. The pain is real. It's called phantom because the extremity is no longer there. But the pain is there. The pain is real. And studies have shown that we all have a 3D map of our entire body in our brain, our spinal cord. And whenever you have a trauma to any part of your body, you will have changes the level of the spinal cord and at the level of your brain. So that 3D representation of that missing extremity is still in your brain and still functional. And I have patients that they say, Dr. DeCastro, I had an accident this morning because I got up thinking that I had my leg and I fell because my leg is not there. They have what is called phantom sensation.
Wow.
They feel their extremity. They have pain in that extremity before the surgery. They're going to have the pain. The pain is going to be there, and the pain might remain there for the rest of their life. So it's a condition that must be treated. The pain is in their head, literally speaking, because of those changes in the CNS, the central nervous system. Another misconception regarding pain is, as you said, that people had a tendency to ignore or rationalize when it comes to others and say, it's in your head, and it's in your head because, as I mentioned before, there's no way for me to visualize the pain. There's no way The same way I can visualize, as I mentioned, the blood pressure or increasing heart rate or increasing temperature with a thermometer, with a sphygmomanometer, with a vital sign monitor. With pain, we can't do that. So if we can see it, it doesn't exist. Another misconception that I see in my practice is family members coming with the patient and concerned about the patient becoming addicted, especially when you use opiate medication.
Yeah, that is a big misconception.
For the treatment of pain. And this misconception about you becoming an addict is not real. Studies have shown that less than 1% of patients treated with narcotics, when treated properly, and in reality they do have pain, less than 1%, if any, get addicted to any narcotic therapy. Anyone will become dependent on the usage or use of narcotics. There's a physical dependency, which is different than a psychological dependency that is the definition of addiction. If you use narcotics medication, opiate medication, to feel good, to have a good time, you will become addicted. Right. But if you use it for someone in pain, that person has less than 0.5% chance of becoming addicted, because that reward mechanism associated with the use of opiate is not there when you're in pain.
You know, and that makes a whole lot of sense, because I'm going to use myself as a guinea pig right now. When I had my surgery about a year and a half ago, I was given, I forgot what the pill was. It was a pain medication, very strong. It's a very, very strong pain.
Is it Vicodin?
Oxycodone?
Vicodin?
It could have been.
Maybe Percocet, Oxycodone.
That one, it sounds just like that one. But anyhow, it's when I took it, my pain went away. Loved it. Then when it started to wear off, I started to feel the pain again. I probably took that medication for about a month. The pain, at that point, I really didn't have the pain anymore. But I just like the way the feeling of being high. And I know that at that point, if I wanted to continue to take the pill just for that high, that's the addiction. Am I correct?
It could be a physical dependency.
Because I stopped at that point.
And if it becomes a psychological dependency, that's the definition of addiction. Then, of course, you can become addicted to it. That's why we as provider must be aware when we decide to use opiate therapy for the management of pain, because this potential risk, and we had to have safety checks in place.
Correct.
In order to prevent, that's basically a complication or associated with the use of narcotic, in order to prevent, complications like that.
Right. Yeah. I remember I had a surgery about 2 years ago, and my doctor prescribed me, I think she prescribed, I want to say it was Vicodin. For pain management.
That sounds familiar too. I could have had that one also.
And so she prescribes it. My mom, she goes to pick up the prescription, and my mom comes home, and I'm like, she gives me one pill, and then I'm like, so you're gonna leave it on the nightstand, so in a couple of hours, like
that
whatever it's
no offense. Put you to sleep. You have a good night's sleep. It's great.
Yeah, so I was like, so, are you going to leave it? She was like, absolutely not. I will ration these off to you. So yeah,
like you're a real addict.
Yeah, and I was like, I actually feel real pain, Mom. And she's like, no, you're not going to get addicted on my watch. So, there is definitely a lot of stigma, and that is a huge belief, especially in minority communities, that you're instantly going to get hooked on opiates if you have pain.
Right, and it's worse when you see patients, for example, with chronic pain conditions like cancer, for example, that they bring your medications on their medical visits, and when you do a pill count, you realize the patient is not taking the medication, and they tell you, well, I don't want to become addicted to this medication,
right.
and say, well, there is always a possibility, but studies have shown that as long as you have pain and you use it for pain, you will not become addicted. So yes, there's a lot of misconception about that.
Right.
Mayana, can you throw out real quick before we go? We have about 2 minutes left. Can you throw out some statistics right now as far as pain management? How much is costing the U.S.?
Yeah. So first of all, this was really alarming to me when I did some research earlier today, that over 100 million Americans suffer from chronic pain. That's a lot of people. That's crazy.
That's almost everybody.
Yeah. So it's costing us about $560 to $635 billion spent on healthcare due to pain, and that was in 2010. There's no anything more recent than that, but that's pretty much what I've found. It's about 14% of all Medicare costs. Let me see. It paid out about $99 billion in 2008 in medical expenditures.
Yes, and that's going to
pain.
And that's going to and we already know that's going to excel and get higher as more people get on Obamacare. I love calling Obamacare. As more people get health insurance, correct. As more people get on health care, it's going to go skyrocket.
And that's it's important to mention that statistic basically for 2010. So the situation is even worse now, and in the sense that the tendency is for costs to go higher and higher, and those numbers are not even taking into consideration the fact that many patients, when they are in pain, they don't go to work. And some family members might stay with those patients, providing, care, and they had to prevent. They don't go to work either, and that add to the cost. Right. Not only that, if you're not working, you're not producing any money. You're not going to pay as much taxes as you would. Correct. So there's always these associated costs that. We don't take into consideration, and when you see numbers like $600 billion, correct. That number is actually underestimating the real problem. It's probably a lot more than that.
Yeah, wow. Something like that really affects the economy because we call that in my profession unproductive hours. We have to pay individuals for sick time. They're not working, but you still have to pay them. That's an increase in cost. Right
and then
there.
You also got to consider that, so if I'm in chronic pain, I'm going to stop exercising as much. That causes, that's going to lead for a risk for obesity. Also, I can't work and do as much as I need to do. So I'm going to lose money on my part. I'm probably going to become depressed, especially if I'm the primary breadwinner in my family. So that can lead to like other mental health other mental health issues or conditions.
Depression, there, especially in our community too.
Right.
Absolutely. There's a lot of psychosocial aspects that tie into it.
And another underestimation with those numbers is that the 100 million Americans suffering of chronic pain were adult, 18 and older.
Wow. So
this is not even taking into consideration children.
Correct.
Wow.
And this is chronic pain. This is also not taking into consideration acute pain. So technically speaking, is an underestimated problem.
So pretty much we're all in pain, basically.
Well, we suffer some type of pain at some point in our life. Yep.
Makes sense. You're listening to Health in Harlem on Whcr 90.3 FM, the voice of Harlem. We're going to take another quick break, but please hit us off. Give us a shout out. 212-650-6903. That's 212-650-6903. We're going to take a very quick break. We'll be right back.
WHCR 90.3 FM, New York.
Welcome to WHCR's Community Calendar, keeping you abreast of events in Harlem and throughout the tri-state area. The following events will take place from Friday, September 18th through Friday, September 25th, 2015. On Sunday, September 20th at 11 a.m. on Governor's Island is the 11th Annual Family Day African Film Festival. The festivities include West African and Jamaican cuisine, African diaspora dance classes, arts and storytelling, and short film screenings to take you on a fun, insightful, and inspiring journey. This event is free, and for more information, visit africanfilmny.org. On Tuesday, September 22nd from 7 p.m. to 9 p.m. at Raw Space at 2031 Adam Clayton Powell Boulevard is the Uptown Social Justice Story Share. Honor Harlem's legacy of activism with storytelling performances from notable Harlem activists, artists, and musicians. This event celebrates the Museum of Impact, the world's first mobile social justice museum. For more information on this free event, visit 5boroughstoryproject.org. On Friday, September 25th at 11 a.m. at Toro College is the Fall Into Health Fair. The health fair offers flu shots, diabetes screening, HIV screening, bone marrow registration, and more to help the community. This event is free, and for more information, call 646-981-4500. On Friday, September 25th from 5 p.m. to 7:30 p.m. at the West Harlem Piers is Summer on the Hudson Bingo. Bring your own food and beverages to this all-ages, free-to-enter bingo party. A mix of music plays as numbers roll out and winners receive prizes. For more information on this free event, visit nycgovparks.org. If you have an event that you would like to place on our calendar, please call 212-650-7481 or email communitycalendar@whcr.org. Submissions must be made 3 to 4 weeks prior to the event. This is Huma Saida for WHCR 90.3 FM, the voice of Harlem.
WHCR 90.3 FM, New York.
I know it's struggle to survive. Won't you drop your foolish pride and get your healing?
Yes, 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 you got to have healing. This is Sean Shivers, and you're listening to Health in Harlem on WHCR 90.3 FM, the voice of Harlem. And I lost my train of thought.
That's okay. I was going to introduce myself.
Yeah, introduce yourself, Ayana. Go ahead, introduce yourself.
And this is Ayana Cole. Yeah, you know my title. No kidding.
You got me laughing. And tonight we're having a very interesting conversation. We have Dr. DeCastro. He's the director of pain management at Harlem Hospital. And we're talking about chronic pain. Again, I'm going to keep saying this, is that there's a lot of individuals listening, a lot of individuals walking around the community, walking around in general in the city, who's in pain, you know.
Right.
And a lot of times, again, you think that pain is the norm. You think that pain is part of the culture, but it should not be. So again, Dr. DeCastro, thank you for coming on to the show.
Sure.
And Ayana, I see you're very anxious over there, so I know you have a question. Go ahead, let it out.
Okay, so first, I just wanted to kind of establish the difference between physical and emotional pain. How does that take a toll on someone differently, like physical versus emotional pain?
Well, you know, pain is pain.
Right.
No matter what the origin, you know, a physical pain has the disadvantage that is usually associated with disease processes that affect, you know, different organs. You know, I'll give an example: someone with breast cancer, someone with a herniated disc, someone with an amputation. So that's basically, you know, the physical pain, and as I said, is always associated with some degree of, you know, tissue damage, is associated with some degree of injury, or that has occurred in the past or is presently occurring to the patients. And when it comes to emotional pain, it takes a different dynamics. It's more complex, you know. I'm talking about the psychological aspect of it. Pain has different components. It's not only the physical component, but it's also the emotional components of it that perhaps might be exacerbated by the patient, you know, state of mind. As I mentioned before, we don't have an area of the brain that we can pinpoint as the pain center per se, that you can target for a specific treatment. What we have is what we call a neural matrix. We have different areas of the brain, the cortex, the thalamus, the hypothalamus, that are all integrated and receiving fibers. And the outcome of a painful experience is basically the orchestration of a response by activation of all these different areas. And that's why it's so complex.
Let me ask you a quick question, and talking about the complex piece. Have you ever, like, stubbed your toe and then, like, you know it's going to hurt, and you're waiting a couple of seconds, and then the pain just hits you. What is there a name for that or a reason for that?
Yes, there is a reason for that. It's a physiological reason because we have nerve fibers throughout our body, connecting every part of our body with the CNS, with the central nervous system, going through the spinal cord. And those types of different nerve fibers, they conduct pain at different velocity. And there is a time lag between the injury and your brain perceiving the sensation as pain. Due to the physiologic difference of those nerve fibers that could be activated by different stimuli, burning, for example, sensation that might occur as a result of a burn. Another example is temperature, cold weather. Those 6 fibers that get activated will conduct the pain sensation at a different speed than beta fibers or other type of fibers that we have integrated into the nerve structures.
Thank you for I never knew that. So thank you for explaining that. I know something now.
So something that was really not really shocking that I found was that women experience more pain than men over their lifetimes, and the pain is seen to be more intense. Can you tell me a bit more about that?
Is that because of pregnancy? Is that one of the reasons why?
I don't know, but we go through some things.
Well, we all experience pain in a different way, and many factors associated with it. We have genetic factors, we have social factors, and cultural factors involved in how people perceive pain. Some people are more sensitive than others. Some ethnic groups, according to some studies, have been found to experience pain more than others when they conduct experiment under controlled environment. For example, they have found that Hispanic and African American are more sensitive to painful stimulation than our, white brothers, to give an example. But interestingly, when you do, when we done studies in terms of the treatment disparity when it comes to pain management among different ethnic groups, then you find study that says, for example, that whites receive double the amount of opioids versus African American or Hispanic in a control setting when it comes to treating the same condition. They have hypothetical patients mimicking, for example, low back pain or a kidney stone, and the only difference is the color of the skin.
Right. I've read a lot about that.
Yes, and there's study done.
Interesting.
Yes, there's study done, and there's racial disparity in the treatment of pain, and there's also gender disparity in the treatment of pain. There's tons of studies out there showing this disproportion. And the reason why institutions like Harlem Hospital in our community is important to support, because it's a way of breaking through these disparities, through these prejudice and bias when it comes to healthcare in treating patients with different ethnic background.
Gotcha. And I thank you for bringing it up just like that, because we're going to jump right into the question now as far as the treatment of pain. You gave a lot of information. We had a great discussion about pain, what pain is, different gender, culture, etc. So now you get a patient at the hospital, who is in pain. How do you assess them? How do you treat them?
Well, we start as with a history and physical on the patient. We try to determine the source of the pain, the cause of the pain, and if it's a condition that could be treated, for example, someone with a cholecystitis, you want to treat the condition first. If it's a gallbladder, because the patient has acute cholecystitis due to a gallstone, you want to remove the gallbladder. You just don't want just to treat the pain. By treating the condition, the pain will go away. Someone with appendicitis, you want to remove the appendix because if you don't do that, the patient's life is at risk. At the same time, you want to provide adequate pain therapy. It's not only identifying the reason why the patient has the pain, but it's also treating pain itself. Because if pain itself is a cause of increased morbidity as well as mortality. So pain is a disease on itself. So we identify the problem, we treat the problem, but we're also going to treat the pain. Now, how we do that, it depends on the type of pain. Someone with a pain that is mild in intensity, you will use medication, for example, like acetaminophen, the aspirin. Someone whose pain is severe or moderate in nature, you might decide to use opiate pain medication. You might decide to use interventional procedures that are like nerve blocks, epidural, for treatment of the severe pain condition. So we basically use an approach that it depends on the origin of the pain. So we have medications and we have procedures.
You know what, and I thank you for putting it like that, because when I asked the question, how do you treat pain, the first thing I thought about is that you were just going to start talking about the different medications, etc.
Yeah.
That's the quick fix. You jumped over that and say, okay, if somebody has pain in their gallbladder, we're going to address the gallbladder. Or if someone has appendicitis, we're going to take out the appendix. See, and I think that people, as far as treatment, don't think about it like that.
Right.
And you just turned my mindset, and I thank you for that.
Yeah, people only tend to scratch the surface of pain when it comes to explaining it. So, yeah, definitely. Thank you so much
Well,
for that.
we try to do both at the same time. You
Right.
know, you do a diagnostic and you also approach with a treatment, you know.
Right.
Gotcha. But, you know, before we go on, because it's 7:45, we're going to take a very,
really?
very, very quick break.
Aw.
And we're going to come right back. You're listening to Health in Harlem. You're listening to Health in Harlem on WHCR 90.3 FM, the voice of Harlem. Again, as I said, we're going to take a very quick break, and we're going to be right back.
WHCR 90.3 FM, New York.
Hi, I'm Vinny B of the Vinny B Showcase. Tune in every Thursday from 8 to 12 midnight for some solid cultural roots music and some sweet lovers rock. Also, informative interviews and giveaways. Right here on the Vinny B Showcase every Thursday, 8 through 12 midnight on WHCR 90.3 FM. Peace.
WHCR 90.3 FM, New York.
Good evening, everybody. Once again, this is Sean Alexander Shivers, and you listen to Health in Harlem on 90.3 FM, the voice of Harlem.
And the greatest in talk radio.
Hey.
Hey. Oh, so wait. I got to do it for Mo. This is Ayana Karima Cole. You know, the middle name is for Mo.
And was it Maurice Donovan Selby?
Yes, that's it. Yep.
Mess. Our show tonight is pain management. Again, please, I hope you're listening. After this show, I want you to go get yourself checked if you are in pain and you're not feeling well. But Dr. DeCastro, he is the director of pain management at Harlem Hospital Center. And we're going to jump right in because we don't have that much time and we have a lot to talk about. But Ayana, you do have to mention that announcement.
Yes, you know, every week the Farmers Market is hosted by Harlem Hospital Centers. It will be held all year, every Friday from 8 a.m. to 7 p.m. on Lenox Avenue between 135th and 137th Street. And during that time, just as a reminder, Parking is not permitted. So come for a wide selection of fruits and vegetables. We accept WIC FMNP coupons, senior FMNP coupons, Health Bucks, SNAP, EBT, debit, credit, cash, everything you got. We take.
You notice that you say cash, debit, and credit last.
Listen, I go down the list.
It's all good.
Oh
it's all
boy.
good.
So
Okay.
let's jump right back into treatments.
Go ahead, right back to treatment, and you can start it off.
Okay, acupuncture, because there's a lot of discrepancy over acupuncture. One, for me, because it looks really scary, so I'm not I don't know if I want to try this out if I had pain or anything. So can you just tell the listeners a little bit more about acupuncture?
Absolutely. Acupuncture is basically part of a long tradition of Chinese medicine, and it's being used for thousands of years, in Asia. Acupuncture actually has a physiologic basics for the treatment of pain. Acupuncture itself has been proven to produce or activate the release of your own natural opioids produced in your brain, your enkephalins, your substances that are basically similar to morphine, so to speak, and these enkephalins, these alkaloids, basically activate opioid receptor and produces analgesia. Is actually higher than placebo in scientific studies. So acupuncture does work. And we use acupuncture for pain management. Variety of conditions being treated, and patients with spinal cord injury, patients with post-laminectomy pain syndrome. Those are patients who have fell back due to 4, 5, 6 back surgery. Surgeons and doctors don't want to deal with those patients anymore because they are in high doses of opioid medications, and they send it to the acupuncturist, and it's very effective. It minimizes the use of opioid. The only problem with acupuncture is that it doesn't last long. So patients might have relief for a week or two, but after that, the patients will have to come back to the clinic for another session of acupuncture.
So now you have mentioned earlier different types of pain medication, different types. The question is that how do you know? Can you mention those pain medications again? And then the other part of the question is, how do you know which one to use for the situation that the patient is in?
Okay. Well, we use this medication actually comes as a recommendation of the World Health Organization, where they have recommended what is called the analgesic ladder, where depending on the intensity and severity of the pain, you're going to start with medication that are at the bottom of the ladder, medication like aspirin, medications like acetaminophen, and then as you move up the ladder, depending on the intensity of the pain, you're going to use medications that are considered mild narcotics, medications like codeine, medications like tramadol. Now, as you keep moving up the ladder, then you might decide to use what we call adjuvants. Adjuvants are non-narcotic medication, but are proven to relieve pain. Medications like vasorelaxant, medications like antidepressant, medications like amitriptyline are used as a coadjuvant. And we do that in order not to maximize the use of opiate pain medication because of the side effects associated with it. As the pain increases, then you use more powerful opiates, medication like morphine, medication like fentanyl. Fentanyl actually are a synthetic opiate, man-created opiate. The most I don't want to say safer drugs on the market because they do have the potential side effect that might cause respiratory depression. But if you do secure the airway in those patients, medications like fentanyl are very safe to use. They're basically known ceiling. You can use as much as you can without any major side effects. And then you move on to procedures, you can combine procedures, like I mentioned, with epidural that is the insertion of a plastic catheter into the epidural space close to your spinal cord to deliver local anesthetics. So local anesthetics are other pain medications that we use, but you use those in combination with nerve blocks and interventional procedures.
So when you talk about pain management and anesthesiologist, are there any comparison?
Pain management is a subspecialty of anesthesia.
Okay.
And anesthesiologists by nature are trained to relieve pain. You know, we are trained in regional anesthesia because we had to get involved with C-sections. We had to get involved with what we call labor analgesia. Patients want to have their babies with minimal pain. We are involved in regional anesthesia to provide regional blocks, someone with a surgical procedure that is going to be performed in one of the extremity. You don't need to put that patient to sleep. You can do a regional block. You can block the brachial plexus. You can block the lumbar plexus. So you don't necessarily have to go general all the time. So anesthesiology have by nature this expertise, and that's the reason why many go into pain management and bring that into the field.
So for some of the listeners who may or may not be in pain, what do you think would be their first step? Well, not necessarily may not be in pain, may actually be in pain. What should their first step be? Should they contact Harlem Hospital and see you? How does it work?
If it's a typical pain that you're familiar with, it's due to your menstrual period, for example, you just have the usual headache associated with it. I guess you take your medication, your usual medication, your usual Advil, which is ibuprofen, your acetaminophen or your aspirin. Now, if that doesn't control your pain, you definitely need to seek medical attention because pain itself is sometimes an alarm mechanism. Sometimes it's a red flag. It is a subjective symptoms that sometimes relay more serious condition. An example, you had chest pain, it might be just osteochondritis, swelling on the costal cartilage, or it might be perhaps a myocardial infarction. A severe headache might be a sign of an aneurysm. It might be just a regular migraine. So a pain that doesn't go away with the traditional way of managing the usual regular pain condition that we all deal with, you just look for medical attention.
Okay.
I'm curious to know when it comes to marijuana, why are individuals allowed to smoke marijuana as far as to address their pain, opposed to taking a pill that's about the same equivalent? Is it because it's natural? I've always wondered about that.
Well, first of all, we need to at this moment in time, we're not using medical marijuana, in New York City. Okay. There is a process going on, and at some point in the future, perhaps we'll be able to do that.
But let's say like Colorado somewhere.
Right. So there are components of marijuana that definitely have analgesic properties. And, for example, there is a medication called Marinol that is the active component of marijuana or cannabis, formulated into a pill that is given to patients, but is only FDA approved for patients with nausea and vomiting associated with chemotherapy, for example. So any other use will be off the label use.
So basically you're saying that if an individual, as far as chemotherapy, they might allow them to take that drug because of the vomiting and the symptoms.
Nausea and vomiting, that's the main indication, yes. Right. And the other issue is with cannabis or marijuana, or the medical use of it, is that in pain management, we're willing to use any drug, any procedure that might benefit the patient in terms of relieving their pain. We're open-minded in that sense, but we need to take in consideration the fact that any medication that you use should be used for that particular patient and that particular patient only. So we must create the mechanism to deliver these drugs just for the intended user. You know, you don't want to prescribe marijuana to grandma and she's due for her marijuana dose at 6 o'clock in the morning.
The way you
and
say
then
it. Marijuana for grandma.
to treat her pain.
Hey.
And then grandma is smoking her dose of marijuana for pain, but Junior is next door also, you know, sniffing and so we
Making
need
brownies.
right. We need to make sure that the moment we decide to do this, we have all these safety guards in place. Medications are to be used by the intended user
Correct.
and no one else.
Absolutely.
Right.
And you know, so funny, that's the best commercial that I've ever seen is that when they show the grandmother, the grandfather at the sink in the bathroom taking their medication, and then they close the door and their grandson is standing in on the opposite. So basically it's saying that your kids may be taking your medication, be wary. It was
Right.
Right.
Great.
Yeah.
Great. So it is 7:58. I love telling
Wow.
the time. Dr. DeCastro, I would love to thank you for coming on to the show. But as we wrap up, can you please let the listening audience know what is, out of this whole conversation that we had, what is the most important thing that they should remember?
Well, they should remember that pain management is an equal opportunity offender. It doesn't discriminate. And we all going to suffer some sort of pain at some point in our life. And, you know, when that moment comes, I want the people to know that Harlem Hospital, as a beacon of hope, is going to be there for the community and will be taking care of the community with state-of-the-art medical care, regardless of your ability to pay for the
Correct.
service.
We say that all the time. And as we always says, is that healthcare, not being in pain is your right as a human. It's not a privilege. It's your right.
You're right. Absolutely.
We throw that out there. So Dr. Castro, if anybody wanted some more information or who's listening and may have some type of chronic pain, is there a number that they can call at Harlem Hospital?
Yes, we have actually the pain management clinic that they can contact at 212-939-3965. And we also have the main hospital phone number for clinic appointments that is 212-939-8400.
Can you say those two numbers one more time?
Absolutely. 212-939-3965, the pain management clinic, and 212-939-8400, the main hospital phone number for clinic appointments.
Excellent, sir. Again, I want to thank you for coming on to the show. And I also want to thank my girl, Ayana, for holding it down, helping me out over here.
No problem. Anytime.
And what's
Love
going
being
on
here.
next week?
So next week is October.
Already?
Yeah, already.
Winter.
I know, right? It's Domestic Violence Awareness Month. It's Breast Cancer Awareness Month. The American Pharmacist Month, and Pastoral Care Week. So on October 1st, we're going to talk about domestic violence and its impact on children specifically. So we'll have Miss Janet Wise Thomas come talk to us a little bit more about that.
Excellent, excellent. So please tune in. I want to give a quick shout out to Mo. I know he's working real hard in the emergency room at
Hey,
Downstate
Mo.
Medical. And I also want to give a shout out and say thank you to Valerie Wright and Nancy Simmons. Those are my girls, my peoples. And without them, we would not get great guests like Dr. DeCastro coming on to the show. This show is in honor of Miss Gloria Thomas. And we're about to check out. See you later.
Oh.
Adios.
I'm like, what? See you later.
You know, it's so funny. I don't
Welcome,
get I don't get a chance to come on the microphone that much, so sometimes I have to remember and get my thought together.
No,
But Harlem,
okay.
please make sure you tune in next week.
Right, take
And
care.
thank you. Take care of yourself.
WHCR 90.3 FM, New York.
Oh, wisdom, you got to have it, yeah. Oh, wisdom. and smile. Don't be shy with love in your arms. You got to be conscious. You got to be righteous. Can't you see the sign of the time?